point several times on this meeting, what we really need is to have a tailored therapy. That means who is really going to benefit from TPF? Who is really going to benefit from cetuximab? And I think what is now the problem of the clinical trials, that the translational research parts are not powerful enough. We really need to work on this problem, that maybe in 10 or 15 years, and that means if we want to have the knowledge in 10 or 15 years from now, we have to do it in the studies we are designing right now. To have a really strong translational research part to identify really predictive markers. Okay, that's all.
Excellent. Any question or comment for Dr. Budak? Marsh?
So I agree with you. It's very important to get translational endpoints. The difficulty here is that the funding for these comes out of either governmental organizations, which don't seem to want to fund industrially sponsored trials for translational endpoints, and the industry generally doesn't seem to want to approach translational endpoints. I think the EGFR lung cancer story is an example of that, where it was actually done internally by several different academic centers and was not really a funded project out of the pharmaceutical firms. And I think what we need to remind the pharmaceutical firms is that what's good for science is actually good for business and good for patients, that good science will be good for their business models and will help them to achieve a better outcome as we achieve a better outcome. And I think we might want to encourage our governmental agencies to try and have partnerships with pharmaceutical firms suitably monitored, but to get to these kinds of questions. And I think that might be very helpful.
I always tell him the Herceptin story, because if Herceptin, if nobody had looked at HER2 new, Herceptin wouldn't have been a success, not at all. So this is the proof that you need to do it.
Good piece of advice, Marshall. Thank you. Our next speaker is Dr. Ezra Cohen from Chicago. Ezra?
Well, I have no slides, and I'll be brief. And I'll make some specific points regarding the day and the discussions. It's interesting to me, and I'll thank, again, the organizers for inviting me. This is the first time I've been able to attend a meeting like this, that 20 years after the VA larynx trial, we're still talking about whether we should approach many of these diseases with surgery first or with a primary chemotherapy radiation. And perhaps if we think about it, it shouldn't be surprising, because as those decades have passed, both or all of the modalities have really evolved and gotten much better. So we're at a point where we can discuss, in a sense, organ preservation surgery as well as organ preservation non-surgical approaches. And maybe we need to revisit these issues and plan randomized trials with the updated modalities. And I think that came up in almost all the organ subsites that we talked about today. Another point that was touched upon by a number of the panelists is the idea behind risk stratification, and specifically the use of induction chemotherapy to stratify risk. And I would say two things to that point. First, I think there are several studies that demonstrate that induction chemotherapy is a predictor, is a prognostic marker. That is, the response to induction chemotherapy predicts prognosis. However, I don't think we can extrapolate from that with respect to deciding what therapy one should get. And what I mean is, although some groups have worked on this hypothesis that patients who have a good response then should go on to get chemotherapy radiation, and those who have a poor response should go on to get surgery, that truly has never been tested in a randomized prospective manner. And maybe it's time to test that. That is, we should, perhaps it's time to look at induction chemotherapy and then randomize patients based on their response to the treatment, that is chemotherapy or surgery. Because I think those patients that don't do well with induction chemotherapy will do poorly no matter how we treat them, unfortunately. And then looking forward, past that, then we can begin to make decisions as to perhaps de-intensifying therapy for some patients and intensifying therapy for others based on that response. Third point I wanted to make was regarding HPV and HPV positivity. In my mind, we are seeing a different disease, and I think the data are really fairly robust, or very robust, and now beginning to tell us that we are seeing a disease of the oropharynx, mostly of the palatine tonsil, without the traditional risk factors associated with squamous cell carcinoma of the head and neck that are HPV positive. We are not ready to make the leap to de-intensify therapy in these patients, at least in my opinion. We have a sense that these patients do better, and again, I think we need to study this question prospectively, because indeed they may be doing better because we are applying all three modalities to them. And if we begin to go back or to step back in a curative setting, we may be doing these patients a disservice. So this is now a question I think that needs to be addressed prospectively. And then finally, along the same lines, much of the discussions today focused on our data, the data from our center included, looked at single institution reports, retrospective reports, or even if they were multi-institutional reports, they were phase 2 data. And I really think if we are going to move our field forward, we need to do it with phase 3 data, with randomized studies, and most importantly now that we're curing the majority of the patients that we see, we need to do it with functional long-term outcomes. And clearly we have ways to study that, and we need to incorporate that as well as looking at translational studies into future trials. So with that in mind, I'll end my comments.
Super. Thank you for being brief and without slides. We're going to hold questions for Dr. Cohen until after we finish with Dr. Vermorken. Jan?
Yeah, well, I have some slides. I hope you don't mind.
Let's proceed.
So, well, there's a lot of information given during these 2 days, and I will say a few words about how I interpret it, and as I already mentioned, the importance of randomized trials. And so if we're looking what way we go, it's important also to go back on why we are doing things. So first of all, the goals in the treatment of head and neck cancer are to remove the cancer load, but to maintain the quality of life and prevent subsequent primaries. And especially, I think, maintenance of quality of life is a very important issue, and we have discussed that also during these days, that maybe we should focus a little bit more in our trials on the quality of life of patients on the long run after they have been treated. And I think what we also learned was that we cannot repeat that enough, that multidisciplinary decision-making in how we treat our patients is essential if we want to see the best options for the patients in their circumstances. So for early stage disease, it was interesting to see again during these 2 days the discussions between surgeons and non-surgical oriented treatments. I think that is opening again, I think, an interesting discussion for future trials. But anyway, the selection of surgical or non-surgical treatments for early stage disease is based on the primary tumor site, the age, the comorbidity, occupation preference and compliance, quality of life following the treatment, the availability of expertise in radiotherapy or surgery, and whether there was a history of previous malignant lesions. Now, for advanced disease, it's interesting to see if you look at randomized trials, and so for evidence-based medicine, what we have done, we have seen that for locally advanced disease, different forms of radiation, as you see here, so accelerated, hyperfractionated radiotherapy, are a level 1 evidence of improvement over conventional radiotherapy. and also the concomitant use of chemotherapy and radiation, whether it is for unresectable disease or resectable disease or in the adjuvant setting after surgery, are all level 1 evidence for improvement over the standard treatments that we have done before. Induction chemotherapy only very recently came forward. This is from a paper that was published in 2007. You see also that with respect to radiosensitizers, there is one trial with numerazole from Denmark that has a level 1 evidence of improvement. And of course, we have the targeted therapy, the Bonner trial, that showed that this is again an important improvement. The Bonner trial you see here, and the importance of that trial was that the efficacy was better with the addition of cetuximab, but that according to that trial, in the patients that were treated in the US, we got the information from the coordinators that there was no worsening of the acute toxicity, and there was no worse late toxic effects. As I mentioned already before, there are some reports on unexpected toxicities with cetuximab, but as far as this trial is concerned, it seems to be mild and not over what we might expect with radiation alone. And if we compare the data from this trial with the chemo-radiation trials, you don't get the impression that the median survival or the survival advantage, in whatever way you're looking at it, is in any way worse than what we have seen with chemoradiation using platinum compounds. However, unfortunately, no direct comparison has ever been made. What we know also from these randomized trials is that the toxicity with everything that is more than conventional radiotherapy is enhanced. And that means whether we are using accelerated radiotherapy, hyperfractionation, chemoradiation in particular, as you see here on this slide, especially xerostomia, but also late mucosal atrophy is something that is a serious problem. And I think that in the discussion we had in the past 2 days, we are now more worried about the late effects than we have been 2 or 3 years ago. And especially patients who have comorbidities and older patients, in the analysis that was done by Boris and reported to us recently, showed that if we use altered forms of radiation or using chemoradiation, the effect of improvement is mainly seen in the younger patients and not in the older patients. Also important is that, that we see from the randomized trials that have been performed, whether it is in the postoperative setting or in the definitive setting, that recurrences are changing and that the distant metastases are coming up more than in the past. And in fact, the percentage of failures due to distant metastasis is on the right side of the slide, showing you that this is a worrying situation, and that means also that there is a revival of the use of induction chemotherapy. And the trials that have been shown here during the meeting are the ones, the TAX-323, showing a clear survival benefit for patients with unresectable disease. A study that was supported by the US trial in a mixed population of resectable and non-resectable disease, again showing a significant survival improvement. And what's further important for the larynx preservation trials is that the French trial, the GORTEC trial, showed that using the TPF regimen versus the PF regimen showed a better larynx preservation. Now, this is, of course, very important within the context of the discussions as we have had of the RTOG study 9111, where we concluded that chemoradiation still is the best option. I think that, that the answer about what is the most optimal approach for organ preservation is still